Welcome to Men's Health 365, where we explore evidence-based strategies to optimize your health, vitality, and sexual function. After 60, I'm your host, and today we're tackling one of the most common yet least discussed sexual challenges that affects millions of men: premature ejaculation. If you're finishing faster than you'd like, or if your ejaculatory control has progressively worsened over the years, you're definitely not alone. The shocking truth: there's one powerful technique that urologists have known about for decades, but rarely teach their patients because it requires time, commitment, and understanding of pelvic anatomy. Today, I'm going to reveal this hidden technique that can give you lasting control without medications, without side effects, and without numbing creams. Let's dive in. Before we get to the technique, let me share Robert's story. At 63, this software consultant from Portland walked into my office, contemplating avoiding intimacy altogether. He'd been married to his wife Sarah for 38 years. His testosterone was solid at 480 nanograms per deciliter. He had no erectile dysfunction, and his desire was strong. But something had progressively worsened over the past 18 months that was destroying his confidence and straining his marriage. "Doc, I feel like I'm 17 again, but not in a good way," he said, his frustration palpable. "I'm finishing in under 2 minutes, sometimes less than 1. We've tried everything, thinking about baseball, using desensitizing creams, wearing extra condoms to reduce sensation. Nothing works." Sarah is understanding, but I can see the disappointment in her eyes. "I'm starting to feel like intimacy is more stressful than enjoyable. I'd rather avoid it than face another failure." Robert's complaint represents one of the most common sexual dysfunctions affecting men, yet it's dramatically under-discussed compared to erectile dysfunction. Research shows that between 20 to 30% of men experience premature ejaculation at some point in their lives, and contrary to popular belief, prevalence can actually increase in some men as they age. While the medical community and pharmaceutical industry focus enormous attention on erectile dysfunction with drugs like Viagra and Cialis, premature ejaculation gets far less attention despite its profound impact on sexual satisfaction, relationship quality, and overall well-being. What Robert didn't know was that the solution to his problem wasn't in his medicine cabinet or in psychological distraction techniques. It was in learning to control a specific physiological reflex through advanced pelvic floor training that goes far beyond the simple Kegel exercises most men have heard about. Let me explain the science behind ejaculation and why most conventional treatments fail. Ejaculation is controlled by a complex interaction between your sympathetic nervous system, specific muscles in your pelvic floor, neurotransmitter activity in your brain and spinal cord, and hormonal influences. The process involves 2 distinct phases that happen in rapid sequence. First is the emission phase, where smooth muscle contractions move seminal fluid from your prostate and seminal vesicles into the posterior urethra. Second is the expulsion phase, where rhythmic contractions of the bulbospongiosus muscle and other pelvic floor muscles forcefully expel the semen. The timing of ejaculation is controlled by a reflex arc that runs through your spinal cord, modulated by higher brain centers. Research published in the Journal of Sexual Medicine has mapped this ejaculatory reflex, showing that it operates somewhat independently of conscious control, which is exactly why simply thinking about something else or trying to distract yourself rarely works. The reflex has a threshold. When stimulation reaches a certain intensity, the reflex triggers automatically, and ejaculation becomes what researchers call the point of no return, or ejaculatory inevitability. This threshold varies dramatically between individuals and can change over time based on multiple factors, including pelvic floor muscle tone, neurotransmitter levels, prostate health, hormonal status, and psychological state. Here's what changes after 60 that many men like Robert experience. First, paradoxically, while some men develop delayed ejaculation or difficulty reaching orgasm, others experience the opposite: progressively shorter ejaculatory latency and loss of control. This can occur due to changes in neurotransmitter balance, particularly declining serotonin, which normally inhibits the ejaculatory reflex. Research in the International Journal of Impotence Research shows that serotonin exerts a strong inhibitory effect on ejaculation, and declining serotonin activity can accelerate the ejaculatory reflex. Second, prostate changes associated with aging, including benign prostatic hyperplasia, can increase sensitivity and irritability of the ejaculatory reflex. Studies in the Journal of Urology have documented that men with lower urinary tract symptoms often experience changes in ejaculatory function. Third, many men develop weakness and dysfunction in specific pelvic floor muscles, and while weak pelvic floor muscles are often associated with erectile dysfunction and urinary issues, dysfunction in particular muscle groups can also contribute to premature ejaculation. Fourth, anxiety and psychological conditioning create a self-reinforcing cycle. Worrying about premature ejaculation increases sympathetic nervous system activity, which paradoxically accelerates the ejaculatory reflex, leading to faster ejaculation, which increases anxiety. The conventional treatments for premature ejaculation include psychological techniques like the stop-start method and squeeze technique, desensitizing creams or sprays containing lidocaine or benzocaine, selective serotonin reuptake inhibitors, either taken daily or on demand before sexual activity, and tramadol. Research shows these approaches have varying effectiveness. SSRIs like paroxetine or sertraline can increase ejaculatory latency by 2 to 3-fold when taken daily, as documented in studies in BJU International, but they come with significant side effects including reduced libido, erectile dysfunction, and emotional blunting, essentially trading one sexual problem for others. Topical anesthetics can extend time but often reduce pleasure for both partners and require careful timing of application. The stop, start, and squeeze techniques require significant partner cooperation and can disrupt the natural flow of intimacy. What all these conventional approaches miss is addressing the underlying physiological mechanism that offers the most direct control over ejaculation without medications or side effects: the neuromuscular control of the pelvic floor, specifically learning to voluntarily modulate the ejaculatory reflex through advanced pelvic floor training. This is the hidden trick that urologists rarely teach because it requires significant time investment to explain properly, detailed understanding of pelvic anatomy, and patient commitment to practice. It's far easier for a busy urologist to write a prescription for an SSRI that takes 5 minutes than to spend 30 to 45 minutes teaching advanced pelvic floor techniques. But the research is clear. This approach works. It works without side effects, and it provides lasting results that continue to improve even after training ends. Here's the technique that changed Robert's life: reverse Kegels, combined with pelvic floor relaxation training and strategic muscle isolation. Most men have heard of Kegel exercises, which involve contracting the pelvic floor muscles as if stopping urination. These exercises, developed by Dr. Arnold Kegel in the 1940s, strengthen the pubococcygeus muscle and are commonly recommended for urinary incontinence and erectile function. However, for premature ejaculation, standard Kegels can actually make the problem worse. Here's why this is critical to understand. The bulbospongiosus muscle, which contracts rhythmically during ejaculation to expel semen, is strengthened by Kegel exercises. If this muscle is already overactive, or if you lack the ability to consciously relax it, strengthening it further can accelerate ejaculation rather than improve control. What Robert needed to learn wasn't how to contract his pelvic floor muscles harder. It was how to consciously relax them, particularly during high arousal, and how to reverse the automatic contraction that signals the approach of the point of no return research published in Therapeutic Advances in Urology examined pelvic floor muscle training for premature ejaculation and found that men who learned both contraction and relaxation techniques, with emphasis on relaxation and awareness during sexual activity, showed significant improvements in ejaculatory control. Some studies showed increases in intravaginal ejaculatory latency time from under 1 minute to over 3 minutes, with many men achieving even greater improvements with continued practice. Let me explain the anatomy so you understand what you're working with. The pubococcygeus muscle runs from your pubic bone to your coccyx and forms the floor of your pelvis. Contracting it creates the sensation of pulling everything upward and inward. It's the muscle you use to stop urination midstream. The bulbospongiosus muscle wraps around the base of your penis and the bulb of the urethra. This muscle contracts rhythmically during ejaculation to expel semen, and it also contracts involuntarily as arousal increases and ejaculation approaches. Here's what most men don't realize and what changes everything once you understand it. As sexual arousal increases, these muscles progressively tense in an automatic, unconscious pattern. This tension is part of the ejaculatory reflex. It's your body preparing for ejaculation. By the time you consciously recognize you're approaching ejaculation, these muscles are already significantly contracted, and the reflex is nearly inevitable. The trick is to develop the awareness to recognize this early tension and the ability to consciously release it, essentially interrupting the reflex arc before it reaches the point of no return. This is the skill that gives you control, the ability to maintain high arousal with a relaxed pelvic floor, rather than the automatic tension pattern that drives rapid ejaculation. The training protocol I taught Robert had 3 distinct phases, each building on the previous one. Phase 1 focused on awareness and identification, which took about 2 weeks. The goal was for Robert to become intimately familiar with his pelvic floor muscles in a non-sexual context, learning to feel the difference between contraction and relaxation. He began by practicing standard Kegels, contracting the muscles as if stopping urination, holding for 3 seconds, then releasing. This taught him what contraction felt like and where these muscles were located. Then he practiced the critical component that most men never learn, conscious relaxation. After each Kegel contraction, instead of just releasing and letting the muscles return to their resting state, he actively focused on pushing downward gently, as if beginning to urinate or have a bowel movement, which actively relaxes the pelvic floor muscles. This is called a reverse Kegel, and it's the foundation of ejaculatory control research in physical therapy literature. Emphasizes that learning conscious relaxation is often more difficult than learning contraction, because we don't typically have voluntary control over relaxation. Our nervous system handles it automatically. Robert practiced this 10 times daily, alternating between contraction and active relaxation, developing the neural pathways for voluntary control. He also practiced during urination, starting the stream, stopping it completely with a Kegel contraction, starting again, and paying close attention to exactly which muscles were involved and how voluntary control felt. Phase 2 focused on arousal awareness and muscle monitoring during self-stimulation, which took about 4 weeks. This is where the training transitions from non-sexual awareness to sexual application, and it's absolutely critical for success. I instructed Robert to engage in solo sexual activity with the specific goal not of reaching orgasm, but of observing his pelvic floor muscle tension throughout the arousal cycle. He was to use an arousal scale from 1 to 10, with 10 being the point of inevitable ejaculation and 1 being no arousal at all. His task was to stimulate himself to around level 5 or 6 arousal, then stop all stimulation and pay careful attention to his pelvic floor. Almost invariably, he noticed that his pelvic floor muscles were contracted, often quite significantly, even at these moderate arousal levels. This was a revelation for Robert. The automatic muscle tension was occurring far earlier in the arousal cycle than he'd realized, setting up the rapid progression to ejaculation. Once he recognized the tension, he practiced the reverse Kegel, actively relaxing his pelvic floor while maintaining arousal. This felt counterintuitive at first, even uncomfortable. Many men unconsciously associate pelvic floor tension with pleasure and arousal, so relaxing these muscles while aroused feels strange or even like it will reduce pleasure. Robert practiced arousal cycles, building arousal to 5 or 6, recognizing the muscle tension, consciously relaxing his pelvic floor with reverse Kegels, allowing arousal to decrease slightly to around 4, then resuming stimulation and repeating. He did this for 15 to 20-minute sessions, 3 to 4 times per week. Phase 3 integrated the relaxation technique into partnered sexual activity with strategic communication and gradual progression, which took about 6 weeks. This phase required explanation and collaboration with Sarah, which Robert approached with some anxiety, but which ultimately strengthened their intimacy and communication. I provided specific guidance for how to approach this. Robert and Sarah would engage in sexual activity with the explicit agreement that ejaculation and orgasm were not the primary goals. The goal was practice, pleasure, and building Robert's control. This removed the performance pressure that had been contributing to Robert's rapid ejaculation. Robert would communicate his arousal level using the scale from 1 to 10 throughout their intimate time together. As he approached 6 or 7 on the arousal scale, he would verbally communicate this to Sarah, and they would pause genital stimulation. Sarah would remain close and maintain intimate connection, touching his chest and arms, kissing, making eye contact, talking softly. But without genital stimulation, Robert would focus intensely on relaxing his pelvic floor muscles using the reverse Kegel technique, actively pushing downward gently while taking slow, deep breaths into his abdomen. This diaphragmatic breathing engages the diaphragm and further relaxes pelvic tension. Research in sexual and relationship therapy has shown that breathing patterns significantly affect sexual arousal and control, with rapid, shallow chest breathing increasing sympathetic activation and pelvic tension, while slow diaphragmatic breathing reduces tension and enhances parasympathetic activity that supports control. After 30 to 60 seconds of this conscious relaxation and breathing, Robert's arousal would decrease to around 4 or 5. His pelvic floor would be relaxed, and they would resume intimacy. They would repeat this cycle multiple times, building arousal, pausing at 6 or 7, relaxing with reverse Kegels and breathing, resuming, gradually training Robert's nervous system to maintain relaxed pelvic floor muscles even at higher arousal levels. The neuroscience behind why this technique works is fascinating. The ejaculatory reflex is mediated by both spinal reflexes and higher brain centers. Sensory input from the genitals travels up the spinal cord to the brain, and when cumulative stimulation reaches a threshold, motor commands travel back down to trigger the coordinated muscle contractions of ejaculation. This reflex includes what's called a feedforward component. As arousal increases, pelvic floor muscles progressively contract in anticipation of ejaculation, and this contraction itself sends signals back to the spinal cord and brain that further advance the ejaculatory process. It's a self-reinforcing loop. By consciously relaxing the pelvic floor muscles with reverse Kegels, you're essentially breaking this feed-forward loop. You're sending signals to the spinal cord and brain that the body is not ready for ejaculation, even though arousal is high and stimulation is occurring. This doesn't eliminate sexual pleasure. In fact, many men report that pleasure actually increases because they're no longer fighting against automatic muscle tension. The relaxation creates space for arousal to exist without automatically cascading into ejaculation. Robert's progress followed a pattern I've seen in many men who commit to this training protocol. During the first 2 weeks of Phase 1, he felt like he was developing good awareness and control of his pelvic floor muscles in non-sexual contexts. The transition to Phase 2 was initially frustrating. During the first few self-stimulation practice sessions, he found it extremely difficult to maintain arousal while relaxing his pelvic floor. Relaxing the muscles seemed to immediately reduce arousal and pleasure. By the end of the second week of Phase 2, he noticed a significant shift. He could relax his pelvic floor at moderate arousal levels without losing arousal entirely, though it still took intense concentration. By week 4 of Phase 2, the conscious relaxation was becoming more automatic, requiring less mental effort. The transition to Phase 3 with Sarah was emotionally significant for both of them. Robert had been avoiding intimacy due to embarrassment about premature ejaculation, and the avoidance had created distance in their relationship, intentionally engaging with the explicit goal of practice, rather than performance, removed enormous pressure and actually brought them closer together. During their first practice session using the pause and relax technique, Robert ejaculated more quickly than intended. Around level 7 arousal, instead of this being a failure or source of shame, they treated it as information. He needed more practice. By their third practice session, Robert successfully used the pause and relax technique 4 times, extending their intimate time from his baseline of under 2 minutes to about 12 minutes. This was already life-changing. By week 6 of phase 3, Robert's baseline ejaculatory latency during partnered sex had increased from under 2 minutes to about 5 to 6 minutes, without using the pause technique at all. And when he did consciously use it, he could extend intimacy to 15 to 20 minutes or more. After 3 months of consistent practice, Robert reported that conscious pelvic floor relaxation had become significantly more automatic during sex. His ejaculatory latency without pausing had increased to 8 to 10 minutes, and when he wanted to extend intimacy, he could easily do so for 20 to 30 minutes. After 6 months, Robert described ejaculatory control as completely different. He felt in control rather than at the mercy of an automatic reflex he could choose when to ejaculate based on mutual satisfaction. His confidence had fully returned. Intimacy with Sarah had deepened dramatically, and sex had transformed from being anxiety-provoking to being a source of joy and connection. Several factors enhanced Robert's success beyond just the pelvic floor training. We addressed his overall pelvic health. Robert had tension in his hip flexors, inner thighs, and gluteal muscles, common in men who sit for long hours. This muscular tension can create referred tension in the pelvic floor. Robert began seeing a physical therapist who specialized in pelvic health, and they worked on releasing these surrounding muscle groups. We optimized his neurotransmitter function through nutrition. Serotonin, which inhibits the ejaculatory reflex, is synthesized from tryptophan and requires adequate B6, folate, and magnesium. Robert ensured adequate protein, including tryptophan, from turkey, chicken, eggs, and pumpkin seeds. He increased B vitamins from leafy greens, legumes, and whole grains. We addressed inflammation, which can increase nerve sensitivity. Robert increased omega-3 rich fish to 3 servings weekly and added turmeric and ginger. We addressed his prostate health because inflammation can increase ejaculatory reflex sensitivity. Robert had mild urinary symptoms, suggesting early BPH. We implemented saw palmetto and beta-sitosterol. We addressed stress and autonomic balance. Robert practiced diaphragmatic breathing throughout the day, training his nervous system toward parasympathetic dominance rather than sympathetic activation that accelerates ejaculation. The psychological transformation was as significant as the physiological. Learning the technique gave him a concrete tool, dramatically reducing anxiety. He wasn't relying on distraction. He was learning to be present, aware, and in control. Let me give you the complete protocol. First, spend 2 weeks on phase 1. Practice 10 Kegel reverse Kegel cycles twice daily. Contract as if stopping urination for 3 seconds, then actively relax by gently pushing downward practice during urination. Stop and start the stream, then practice fully relaxing. Second, begin phase 2, 15 to 20 minute solo sessions, 3 to 4 times weekly. Use arousal scale 1 to 10. Stimulate to 5 or 6. Stop. Notice pelvic tension. Practice reverse Kegels. Allow arousal to decrease to 4. Repeat. Continue 4 weeks. Third, incorporate diaphragmatic breathing. Breathe deeply into abdomen while relaxing pelvic floor. Fourth, transition to phase 3 after developing control. Communicate with partner. Agree practice is the goal. Communicate arousal levels. Pause at 6 or 7. Relax pelvic floor and breathe for 30 to 60 seconds. Resume. Continue 6 weeks. Beyond training, implement lifestyle support. Exercise regularly, 4 to 5 times weekly. Prioritize 7 to 8 hours sleep. Moderate alcohol. Avoid before intimacy. Address stress through meditation or mindfulness. Consider working with a pelvic floor physical therapist for personalized guidance. Robert's transformation after 6 months was comprehensive. His ejaculatory latency increased from under 2 minutes to 8 to 12 minutes baseline, 20 to 30 plus with technique. More importantly, he felt in control, could choose timing, anxiety disappeared, relationships strengthened, quality of life improved. For men experiencing premature ejaculation, this protocol offers science-based intervention addressing the neuromuscular mechanism. It requires patience and commitment, but provides lasting results without medications or side effects. The one trick urologists hide is a learnable skill, giving you direct control over a reflex you thought was automatic. Thank you for watching Men's Health 365. Please like, subscribe, and share.